The Epilepsy Foundation is pleased to bring to you the second of 3 modules in an education series titled Seizures and Epilepsy in Older Adults. This education series is brought to you with support from Synovian. My name is Dr. Elaine Kyriakopoulos, and I would like to extend a warm welcome to everyone who has joined us today. I'd like to share with you the mission of the Epilepsy Foundation: to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. The Epilepsy Foundation and our partners are also committed to working to ensure that older adults living with epilepsy receive the best care possible to improve health outcomes and quality of life. I'd like to review with you the format for today's webinar. Throughout the presentation, all phone lines will be muted. However, we would like to encourage everyone to submit their questions at any time during the webinar. To do so, type your questions into the question window on the GoToWebinar panel and click Send. We will read your questions aloud and address them during the question and answer portion of the webinar. Please keep your questions general in nature, as the webinar is intended for educational purposes. This webinar does not take the place of individual medical advice. This webinar will be recorded and available for viewing and listening on epilepsy.com. I am so pleased and honored to introduce to you today Dr. Michael Gruenthal. Dr. Gruenthal is an epileptologist who serves on the Professional Advisory Board of the Epilepsy Foundation of America and the Board of Directors of the Epilepsy Foundation of Kentuckiana. He is a professor emeritus of neurology at Albany Medical College, where he was the chair of neurology, director of the Neurosciences Institute, and senior associate dean for clinical affairs. We're so appreciative of you being here with us today, Dr. Gruenthal.
Thank you. Very happy to be here.
There are no speaker disclosures for today's webinar. Today's webinar, Module 2 of the 3-part series, will focus on the treatment of epilepsy in older adults and special considerations in this population, whether they are living independently or in a long-term care setting. We will provide for you today a review of the medical management of seizures in older adults, drug dosing and metabolism considerations when treating older adults, common drug-to-drug interactions, the possible side effects of anti-seizure medications, other treatment options in older adults, and seizure first aid. At this time, I'm going to turn the webinar over to Dr. Gruenthal.
Thank you, Dr. Kyriakopoulos. Welcome, everybody. Thanks for participating. We've got a fair amount of material to cover today, so let's jump right in. All right, so let's talk a little bit about the diagnosis of epilepsy. It's important to understand that not everybody who has a seizure has epilepsy. Seizures can occur with other medical conditions. We often refer to these as provoked seizures, and in fact, all of us are capable of having a seizure if sufficiently provoked. We may all have slightly different seizure thresholds, but things like hypoglycemia, hyponatremia, etc., are capable of causing anybody to have a seizure. That's not what we consider to be epilepsy. So we reserve the term epilepsy for a circumstance in which there is a high likelihood of recurrent unprovoked seizures. And you see here on this slide the old definition, not that old, but we used to say 2 or more unprovoked seizures. We've modified that somewhat recently to add to 2 or more unprovoked seizures 1 seizure and some indication of a substantial increased risk for subsequent unprovoked seizures. Oftentimes an abnormal EEG indicating an ongoing susceptibility to seizures, or a structural abnormality on brain imaging, or a clear-cut diagnosis of an epilepsy syndrome. We're not going to really talk about epilepsy syndromes today, but just understand that we've made some recent modifications to the definition. But the bottom line message is that we reserve the term epilepsy for those people with seizures who are at statistically relatively high risk for having additional unprovoked seizures. And as I said, the key to the diagnosis of epilepsy is a susceptibility to recurrent seizures. It's very important to understand that saying that somebody has epilepsy does not tell us anything about the underlying cause or the prognosis. There are many different types of epilepsies. So when we say to somebody you have epilepsy, that's similar to saying to somebody you have a susceptibility to recurrent shortness of breath, or you have a susceptibility to recurrent chest pain or recurrent abdominal pain, etc. It's not indicative of the underlying cause, and our goal is to always identify the underlying cause. Sometimes we can, sometimes we can't, but that's always the goal. There are many different types of epilepsies, and they can have a spectrum of impact ranging from a very profound deleterious effect on daily life and quality of life at the severe end to relatively easy to manage and control at the less severe end. And we're going to focus today on aging with epilepsy. And there are several, I think, important concepts to consider. People diagnosed with epilepsy earlier in life unfortunately age just as the rest of us do. And they will typically, not always, but typically remain on chronic medical therapy. And there are considerations related to aging that we're going to discuss. They are predominantly related to the fact that the body's physiology changes as part of aging. And as a consequence, it's important to recognize that there may be needs for dosing adjustments as people age, and we'll talk a little bit about why that is. Aging can alter all of the components of pharmacokinetics listed here. So drug absorption, metabolism, distribution, and excretion are all affected, at least to some extent, by aging. As we age, we have a tendency to accumulate an increasing burden of medications. And age-related polypharmacy presents substantial challenges at times with respect to drug-drug interactions. And as we age, we also typically develop increased sensitivity or risk for adverse events, either from individual medications or particularly from polypharmacy. So let's talk about treatment. Anti-seizure medications are the mainstay of treatment, and you may be familiar with these as anti-epileptic drugs, or AEDs. It's perfectly fine to call them that. We tend to call them now anti-seizure medications because they treat seizures. They don't really typically treat the underlying cause or of epilepsy. In all age groups, including older adults, anti-seizure medication monotherapy is typically the first treatment choice. There is a dizzying array of anti-seizure medications currently available that gives us tremendous flexibility in what we choose under what circumstances. And of course, we strive for complete seizure control without side effects. Oftentimes, the practical reality is that we have to strike some balance between seizure control and tolerable side effects. In general, the newer anti-seizure medications are better tolerated in the elderly, and we'll spend a little bit of time looking at some of these drugs and why that is. Anti-seizure medications are, to be frank, not particularly sophisticated. They suppress seizure activity, but they do not treat the underlying cause of epilepsy. They suppress seizure activity by altering the electrical activity in neurons and altering chemical transmission between neurons. And unfortunately, for the most part, they affect every single cell in the brain. So they're not selective. And that's why they all have the propensity for adverse events. Those of you who were able to participate in Module 1, I think, learned a little bit more about seizure classification and diagnosis. One of the most important considerations in selecting an anti-seizure medication is seizure classification. Broadly speaking, we divide seizures into so-called focal seizures. These are seizures that start in a circumscribed area of the brain and may or may not spread from there to other areas. And we distinguish that from generalized seizures, which appear to involve large brain areas simultaneously at the onset of the seizure. This distinction is important both for prognostic considerations and for treatment considerations. For focal seizures, most but not all of the anti-seizure medications are potentially effective. For generalized seizures, there are what we refer to as broad spectrum anti-seizure medications that tend to be more effective. There are some circumstances in which treating focal seizure with a generalized seizure medication or vice versa can be of no benefit, or in some circumstances may actually worsen seizures, and that's certainly something that we don't want to do. There are some people whose seizures remain unclassifiable or unknown seizure type, and for those, broad spectrum anti-seizure medications are the best initial choice. Here's a nice illustration of the evolution of seizure medications, anti-seizure medications over time, from the so-called first generation starting well over 100 years ago to second generation drugs and third generation drugs. We're not going to talk about these drugs specifically. Some of them may be familiar to you, many of them may not. That's fine. Some of them have fairly unique or circumscribed uses. But the important point is that we have a growing array of medications from which to choose, and that gives us much more flexibility than we used to have in the past. Some of the commonly prescribed medications, older versus newer, are shown here. Again, we're not going to talk about these individually in detail, but some of the older medications, and if you saw on the previous screen, some of them are over 100 years old. Phenobarbital, phenytoin, still used in some circumstances today, approved in 1938, carbamazepine, valproic acid, and then a larger list of the newer anti-seizure medications. Again, in the box is the important point. Treatment considerations are always dependent on effectiveness for specific seizure types, adverse events, drug interactions, and underlying comorbidities. Some of these medications are actually helpful for some underlying comorbidities and some not. In terms of efficacy, unfortunately, the introduction of new medications hasn't really changed these numbers. There are substantial benefits associated with the new medications, but the fact remains that about 30 to 40% of people continue to have seizures despite available medications. And so again, we spoke a little earlier about this spectrum of, at the left side of the arrow, uncomplicated epilepsy, where seizures are well controlled, ideally with no or minimal drug-related adverse events. to the opposite end of the spectrum where there are frequent seizures, substantial medication side effects, a profound effect on quality of life, and epilepsy can be disabling. There are some other treatment options in older adults. We're not going to talk about these in any detail at all today, but so-called resective surgery, identifying the point of origin of a seizure and surgically removing it, is still the most effective alternative to medications when medications are not effective. There are some newer neurostimulation devices that can be effective. Sometimes dietary modifications can be helpful, and management of seizure triggers, rarely alone, but sometimes as an adjunct to other treatments, can be helpful as well. Anti-seizure medications are, for the most part, metabolized, with a couple of exceptions, and they can be metabolized in the liver, in the kidney, or both. Understanding how individual medications are metabolized is an important consideration in choosing medications, particularly as it relates to underlying medical conditions and other medication. Initiation of treatment is based on the concept of monotherapy, and that's true in all age groups, but particularly in older adults. Monotherapy is always preferred when possible. Choosing an anti-seizure medication, as I said, is a topic that's a little bit complicated in some circumstances beyond our scope today, but depends on a variety of factors, including seizure classification. We always, and particularly in older adults, start at a low dose and titrate slowly. We're going to talk a little bit about levels of anti-seizure medications, but the point on this slide that's important to highlight is the individualized treatment. Not everybody is the same, and the doses and tolerability will vary from person to person. Simple dosing schedules are vastly preferable from a perspective of medication adherence. Once you get past BID, or twice-a-day dosing, adherence becomes challenging for the vast majority of patients. So how do we go about choosing an anti-seizure medication? The first question is treatment the right choice? In most circumstances, the answer is yes, because people with epilepsy are, by definition, at increased risk for subsequent recurrent unprovoked seizures. But sometimes those seizures are few and far between. This is a factor that should be taken into consideration and should be decided in conjunction with the patient or patient's family if the patient is not capable of participating in those decisions. There is risk of harm from repeated seizures. That certainly is a significant motivation for selecting an anti-seizure medication. As I said, the seizure type is the primary determinant of which of the available medications may be appropriate and effective. Drug metabolism, again, based on other medical conditions and medications. And polypharmacy is a substantial consideration, particularly in the elderly, most of whom are on other medications. So the concept of individualized treatment is an important one. Treatment considerations and doses depend on age and functional status. We need to take into consideration comorbid medical conditions. As I said, some of these drugs can actually be beneficial, but can often be harmful depending on morbid medical conditions. These conditions may affect metabolism. People with cardiac disease are on oftentimes one or more other drugs which may pose interaction problems. Because the available anti-seizure medications are not selective and that they affect, as I said, every cell in the brain, they can have a sometimes profound effect on cognition, and so that's a very important consideration. Underlying mood disorders, some of these drugs are actually helpful, and some in fact are even indicated for mood disorders. And bone health, as we'll talk about on a subsequent slide, is an important consideration as well with some of these medications. Ultimately, what we're striving for is the best possible quality of life. Adherence is a challenge. Anybody who's involved in care of people with any chronic medical conditions, epilepsy or otherwise, is familiar with some of the challenges. The dosing complexity can be very challenging and can reduce adherence very substantially. Various reminder tools are very helpful. Paper calendars, pill boxes organized by the day of the week. There are a variety of smartphone apps available now that may be of assistance with this. Individual living situations, whether somebody is living independently or not, can affect adherence. Tolerability certainly affects adherence. Nobody wants to take a medication that makes them feel rotten. Patient education is always important, and I've learned from experience to not take anything for granted. I actually had a patient once come back to see me and said, "I finished the entire bottle of medication that you gave me. It didn't work. I'm still having seizures." And so understanding the perspective of a patient and adjusting the education accordingly, I think, is very important. And cognitive decline, visual issues, fine motor skills, et cetera, can all impair someone's ability to adhere to a medication schedule. And cost is obviously a big factor, particularly in the older population who are on multiple medications, fixed income, et cetera. Adherence can be very challenging. Not specifically shown on this slide, but I'll also point out that we have to ask patients specifically and candidly about adherence. They're often embarrassed or reluctant to talk to us, particularly when things like cost are an issue. So it does take some probing sometimes to get to the bottom of whether somebody is actually adhering to their medication regimen or not. There are a variety of dose-dependent adverse effects. All of the anti-seizure medications, to a greater or lesser extent, are capable of producing dose-dependent adverse effects. And these can be particularly problematic in the older population. So many, if not all, of these drugs can cause balance impairment, leading to risk of falls, confusion, difficulty with ambulation, dizziness, tremor, sedation, and visual disturbance. All of these can be particularly problematic in older populations. So how do we monitor anti-seizure therapy in older adults? Well, as I said, having a candid conversation and getting people to speak candidly about their medication adherence is always important. Measuring the levels of anti-seizure medications can be a useful tool. I think it's important to point out that And levels of anti-seizure medications are relatively broad statistical guidelines that may or may not apply to individual people with epilepsy. In addition, these statistically derived therapeutic ranges typically haven't been obtained in older adults, so they may not really apply to older adults. But measuring levels can be a useful tool, particularly for monitoring adherence to medications. They are useful in individualizing therapy as well. So ideally, when we reach a dose level where someone is seizure-free, ideally without side effects, that's a useful time to measure a level, because then you have a therapeutic range for that individual patient. And the newer anti-seizure medications are generally less complicated in terms of their pharmacokinetics and metabolism. They are metabolized in a linear fashion, meaning that if we double the dose, we're going to approximately double the blood level, and so monitoring is not as important in some instances with the newer drugs. So as we discussed, older adults are generally speaking more sensitive to side effects of anti-seizure drugs compared to their younger counterparts. Next slide, please. And of course, we strive to maximize quality of life in people with epilepsy. Seizures themselves obviously have a profound harmful effect on quality of life, but we can actually worsen quality of life if we expose patients to significant adverse effects that limit their daily activities, limit their comfort, etc. And so we're always striving for a balance between adverse events, some of which will inevitably occur, and quality of life. So the point here is we don't want to worsen quality of life in the interest of eradicating seizures if we're exposing patients to intolerable adverse events in order to eliminate their seizures. Next slide, please. There are possible drug-drug interactions with many of the anti-seizure medications and many of the categories of medications that the older populations are taking, including calcium channel blockers, blood thinners, lipid-lowering drugs, and chemotherapeutic drugs. And so these always need to be understood and taken into consideration in both choosing a medication and in dosing. So we characterize the anti-seizure medications as enzyme inducers, enzyme inhibitors, or in some circumstances, drugs that have little or no enzyme inducing or inhibiting characteristics. In general, the older anti-seizure medications that we saw on that graph several slides ago are potent enzyme inducers. They are shown here: carbamazepine, phenytoin, phenobarbital, and primidone. All these drugs are still in use today. Valproic acid is an enzyme inhibitor. Felbamate, a drug with which you may not be familiar, is also an enzyme inhibitor. And some drugs can be inducers and inhibitors depending on the particular enzymes in the cytochrome P450 system, creating additional complications. The enzyme-inducing anti-seizure medications also affect endogenous biochemical pathways, as shown on this slide. The most important one, at least in my opinion, is vitamin D homeostasis and bone metabolism. So these drugs can accelerate osteoporosis, leading to clinically significant bone demineralization and increased risk for fractures in all populations, but particularly in the elderly who are already susceptible at increased risk for falls, etc. And it's important to recognize that several medications can lower the seizure threshold in at any age, but the elderly may be particularly susceptible. We're not going to go through these drugs in detail, but individual drugs or categories of drugs are listed here. So it's certainly important to understand, particularly if somebody with epilepsy whose seizures are well controlled has recurrent seizures. Oftentimes, one of these drugs or drug categories may be the culprit, so it's important to keep track of the medications that our patients are taking. And let's talk briefly about status epilepticus. Status epilepticus is a medical emergency. It is defined as seizure activity which lasts greater than 5 minutes. That can be a continuous prolonged seizure activity or recurrent seizures without recovering in between seizures. In both of those circumstances, if seizures persist for longer than 5 minutes, that is status epilepticus, and it is a medical emergency. The very young and the very old are more susceptible to this. And the first line of treatment for status epilepticus are so-called rescue medications. These are benzodiazepines. These are drugs that bind to GABA receptors, GABA being the principal inhibitory transmitter in the brain. They are so-called GABA agonists, meaning they mimic the effects of GABA at the GABA receptor. If administered promptly and in proper doses, can oftentimes abort status epilepticus. They are available in an increasing array of administration options, orally, intravenously, intramuscular, rectal, and now buccal and intranasal administration forms. So that out-of-hospital treatment of status epilepticus is increasingly a treatment opportunity. Okay, so seizure first aid. Next slide, please. So, what to do in the event of a seizure? In general, less is better. Stay with the person. Start timing the seizure. Again, if seizures, recurrent seizures without recovery, or an individual seizure lasts longer than 5 minutes, that is a medical emergency. Otherwise, the goal is to keep the person safe, meaning moving or directing them away from harmful objects or situations. If the person is not awake and aware, typically this circumstance is a convulsive event. We turn patients on their side. Oftentimes there are substantial oral secretions associated with convulsive seizures, and we don't want those to be aspirated. We want to turn patients on their side, but do not block the airway. Depending on where and when you were trained, you may have been taught to insert an object into the mouth of somebody having a seizure. That is a bad idea in every circumstance. Do not put anything in their mouth. Do not give water, pills, food, etc. until the person is awake and alert. Do not restrain somebody who's having a seizure. That can actually lead to significant skeletal injury. And stay with them until they're awake and alert after the seizure. Fortunately, most seizures end in a few minutes. They can be scary to see if you're not accustomed to seeing them, but they are, with the exception of status epilepticus, self-limited events during which significant harm typically does not occur. Circumstances under which 911 must be called: seizures lasting longer than 5 minutes, that is status epilepticus, that is a medical emergency. Repeated seizures, difficulty breathing, somebody has a seizure while in water, obviously if there is an injury associated with the seizure during pregnancy, if somebody has an underlying serious illness, anyone who does not return to their usual state, that could also be status epilepticus, even if they are not overtly seizing, or a first-time seizure requires prompt medical evaluation.
Thank you, Dr. Gruenthal, for that wonderful overview, and thank you to everyone listening for your attention. We want to share with you ongoing ways to find resources and connect with the Epilepsy Foundation. You can find more learning, support, and resource information via epilepsy.com and our 24/7 helpline. You can also connect with your local Epilepsy Foundation in your state, and they can help to provide resources, support, programs, and services, and can link you to epilepsy providers and community members close to home. I also want to take this opportunity to offer a reminder that next week, epilepsy nurse specialist Lindsay Schomer will be joining us to provide webinar learning about impact and risks for older adults living with epilepsy. I want to once again thank Dr. Gruenthal for sharing his time and expertise with all of us today. I would also like to thank each of you for your interest and participation and for all you do to care for people living with epilepsy. Thanks so much, everyone.